So I'm delighted to welcome Julian Hartley, the new Chief Executive of the Care Quality Commission. Welcome, Julian. We'll just go through a couple of housekeeping slides and then I'm going to hand over to you. Fantastic. I just first of all want to say thank you to our sponsors for the whole Patient Partnership Week, which happens from the beginning, the end of June, from the 30th of June. And Julian is joining us as a preamble to that. So really the launch of our Patient Partnership Week, which is fantastic. And if we move on to the next slide, please. So a lot of people like to watch the webinar afterwards, so this will be uploaded to our website as soon as we possibly can do. Chat box is there, so please do say hello to everybody because it's good for us and nice for us to see who's in the room with us as well. But once we really get into the webinar and everyone said hello, we'll turn off the chat box because people have reported before that they find it quite distracting. The closed caption function has been enabled for those who want to use it, but we are opening up Q&A. That should be open right now. But I just so you all know, because you all, when you register to come to the webinar, you actually also gave us questions and some outcomes of what you hope to expect from today's webinar. And I hope I've done my best to theme those questions because we had over 170 questions. And I've themed them so that hopefully we can get a real range of experiences from Julian. And we will get started now, I think. And everyone, and hello, it's great to see such a variety of people there from sunny Durham as well, which is good. And I think you were joining us from sunny somewhere up north, Julian, and I'm sitting here roasting in London, so dreaming I'm by the beach. So Julian, thank you so much for joining us. And I really felt that then I'm so glad that you agreed to do this with me, because I think the CQC has such a pivotal role. And you know what really matters, you and your family when you need care, you know, when a parent needs a care home or you're choosing your GP practice, we all go and check your CQC ratings, and they aren't just labels, they're there to help us decide whether somewhere is safe and quality for the people that we love. And we know that Dr. Penny Dash's independent review found that the CQC had suffered significant failings and a substantial loss of credibility. So the organisation that's meant to protect us has been struggling to do that very basic job. And our concern as a patient association is when our regulator loses credibility, standards can slip, and therefore patients are put at risk. So I think that's why we're here, not just to talk about the processes in isolation, but to discuss rebuilding the regulator that we can actually trust as patients every day. So Julian, I want to hand over to you. I don't know whether you want to say something about your past and where you came to, but the main question I want to say, is this the CQC that you recognised when you came into role in December 2024?
Thank you. Thank you very much, Rachel. And thank you very much for the opportunity to be here on this webinar. I'm delighted to join you. And can I just say how important the Patient Association partnership that we have with you is, particularly that direct feedback we get from patients and the work we do together to get feedback, and indeed the campaigns we do together on Share Better Care, and really important. So I'm delighted that we're cementing that partnership with these kinds of events, and I'm really looking forward to getting the questions from everyone that's joined. Just to answer your questions, so my background is I've spent my whole career working in the NHS, in the health and care sector, in lots of different jobs, mostly in the hospital sector, but I have worked in primary and community as well. And the importance of those sectors together with social care, we can't underestimate. Turning to this job, well, I started at CQC at the beginning of December. And as you said, Rachel, I came in at a time of real turbulence. The CQC, as colleagues I'm sure will, everyone on the call may recall, following Penny Dash's report, Secretary of State declared CQC is not fit for purpose, which I know would be really concerning for many people that use services, and thinking about the importance of the regulator. Because if we go back to first principles and fundamentals, the role of the CQC is, first and foremost, to protect patients and people that use services, and also to support and encourage providers who deliver services to patients to improve. So we've got those two key roles that were, enshrined in how we were set up. And I think what last year's events revealed through Penny Dash's work was that the CQC lost its way, and it did so for three big reasons, and probably worth just articulating those for context. One was because it moved from if you like, a specialist approach to having specialists in particular sectors who knew all about the kind of services that they were inspecting, to one that was more generalist based. And I think that was a mistake. And I think that was called out as well in the various reports that were done on CQC. I do think if you're a regulator, that your teams need to have a really good background and understanding of the services that they're going in to inspect. And I would hope that, I think patients need to know that the regulator has that expertise and is able to hold the mirror up accurately. The second thing was that CQC moved to what was called a single assessment framework. And this is how we assess providers to rate them. And it moved away from, if you like, specific sector approaches to a general approach that used the same assessment framework for a very small care home and a major teaching hospital. Now, I think instinctively we would all agree one size doesn't fit all and can't fit all. You need to adapt and adjust according to the kind of healthcare organization you're looking at. And thirdly, as we've seen in quite a few public sector organizations, there was a major failure in a new IT implementation. The idea that this single assessment framework could be done on a new regulatory platform, which was a big IT implementation, which I'm afraid was a catastrophe. Not to put too fine a point on it, and coming in, I commissioned an independent review of that, which is on our website if any of you are interested in reading the detail of that. But fundamentally, what it did was it made it almost impossible for inspectors to get reports out in a timely way. It affected the whole working of CQC, and it meant that our operational effectiveness, our ability to do the volume of inspections and regulatory activity we should be doing on behalf of all of you, really suffered. So those three things, Rachel, I think have really brought us to where we are. And of course, over the last 6 months, it's been my priority to try to rebuild and focus on improving that. And of course, those three things had a huge impact on staff in the organisation, their confidence, their sense of frustration in not being able to do their job, and consequently that impacts, as you outlined in your opening, on the confidence that the public and patients can have in the regulator. So huge amount to do. I can say more about what we're trying to do to fix that, but I think, in short, to answer your question, was it what I expected? It was, and some, in terms of the depth and scale of the issues that we're facing.
Thank you, Julian. And I think some of the issues that you raised, those three key points will come up in some of the questions I'm going to ask you today. And I think your point about staff and CQC was really important too, because I really believe strongly that philosophy of care for staff impacts the quality of care the patients get, and that goes for the regulator as well. So all of those issues that you just raised there, I'm going to talk about staffing in a while as well, but it leads to a breakdown of trust. And I just want to ask you, what do you think are the three most important issues that you need to address to regain the trust of both patients, the public, and services?
Yes, great question, Rachel. I mean, I think the first is, I think patients, first and foremost, need to feel that they can have confidence in the regulator to take action when needed, to be clear about what's working and what isn't. And so to that end, we have we have gone back to that sort of specialist expertise, and consequently we have appointed 4 chief inspectors, and that, I think, is an important step, because what that is about is saying that for each of the key areas, which are primary and community services, mental health, and incidentally, this will be the first time the CQC has had a chief inspector of mental health at this sort of level of seniority, which I think is important given the scale of the challenges we're facing in mental health. Hospitals, of course, and adult social care. So those 4 chief inspectors cover the whole range of health and care areas, and each of them comes with very, very experienced and skilled backgrounds in their sectors, and also I think gives us a really strong level of demonstrable kind of diversity and understanding as well. So we've got Dr. Aaron Chopra as our Chief Inspector of Mental Health. Aaron is already with us, and he's doing some important work already in terms of looking at how we can improve our oversight of mental health. We've got Professor Bola Olawabi, who is known to many of you. Bola comes to us from NHS England, where she's been Director of Health Inequalities. And I'd say health inequalities, as the challenge of our age, it's vital that as the regulator, we're really focusing on that. But Bola, of course, has got great experience in both primary services as a GP and community, where she's also been a medical director of community trust as well. Dr. Tolly Onan joins us as Chief Inspector of Hospitals. Tolly is medical director at Manchester University Hospitals and is an obstetrician and gynecologist by background. I mean, I think a very important background to have given the current challenges in maternity across the service. And fourthly, announced yesterday, Chris Badger, currently the Adult Social Care Director at Hertfordshire County Council, but also having done work with the Department of Health on effective discharge and the importance of social care. So I feel like we've assembled a really strong team to actually ensure we've got the expertise, and each of those chief inspectors will have their own teams with expertise in those areas, which I hope will put right the problem I described about moving away from that. So I think that's the big thing, I think, Rachel, is giving patients confidence that the regulator knows what it's doing in terms of its core business, and that it's got people that understand that. The second big priority, the big issue, I'd say, is what is all about making sure we've got really good means of feedback. So sessions like this morning, but also more systematic approaches where we get really, really clear and unvarnished feedback on people's experience of care is vital. I was up in Newcastle yesterday with our fantastic colleagues that are on the National Customer the National Customer Service Centre, and this is where people can phone in with issues and experiences, and we've had a big backlog of concerns, which was part of the problems I described. We've worked through those, got those down. The team have done a great job, but I think that's another important way of capturing feedback. But the whole issue of how we capture feedback and how we use patients in our work. So we use experts by experience on our inspections, which is vital. So I think actually last year our experts by experience took part in around 1,800 regulatory activities and spoke to around 17,000 people using care and receiving care. So we're keen to increase that still further. And thirdly, I'd say that we want to be able to be a regulator that really does understand what good can look like and support improvement. So understanding the importance of culture, understanding how the learning from where things do work. I'm sure many of you on this call have had good experiences as well as poor experiences. What differentiates them? What's the ingredients of great care? How, as a regulator, do we feed that back and share that best practice? So it's those three things, I think, Rachel. It's that building of credibility and expertise. It's the involvement and the feedback from patients and service users, and it's the focus on improvement.
Brilliant. Thank you, Julian. And I'm going to come back on each of those themes that you identified there. And the first one I'm going to come back is with the appointment of Aaron Chopra as your first dedicated mental health chief inspector and your anti-racist framework. And your comments about inequalities and the postcode lottery that exists in care quality. How specifically will CQC ensure that fair quality for all patients, regardless of where they live or their background? And a slight supplement, well, not a slight, but a big supplementary question to that is, how will you hear those voices within CQC? Because they're not coming in as experts by experience.
Yeah. Great question. So I think first thing we've got to recognise, Rachel, is that there is such variation across health and care across the landscape, and I'm sure many of you on this webinar will have experienced that. I think that we as the regulator need to really understand the context of the neighborhood or the community or the area region where that care is being delivered. We need to be really clear about understanding the demographics, the index of multiple deprivation, the ethnicity, the inequalities that exist. And I think we need to encourage providers to do more work on this. So, for example, we know that there are providers who, like, for example, hospital trusts that are looking at analysing their waiting lists by ethnicity, index of multiple deprivation, and so on, to people with learning disabilities, autism, and so on, to understand and ensure that there are not inbuilt inequalities within something you'd argue should be a rational process as far as waiting lists. But actually, we find it isn't. We find there are disparities and inequalities that exist. So the first job is to make sure we understand that they do exist and to highlight them and to call that out. Because it's interesting, you mentioned anti-racism, and when you look at the great work that the Race and Health Observatory do, which Habib and the team do, that the first step in any approach to being an anti-racist organisation is to call it out, it's to understand it, it's to shine the light on where those inequalities exist. So going back to what we do, I think in the context of our work and our investigations, or our inspections, or our regulatory work, we've got to have an appreciation of the context and the particular issues on the ground. That was why having a single assessment framework wasn't helpful in that regard, because it did not get into the level of granularity required. How we make sure that we genuinely get feedback from patients in a way. I mean, I'm hoping, frankly, that Patients Association can help us with that. You've got such strong and effective work and links, and that's why it's great we've got the partnership we have. But I think you can and should challenge us about how we can do more as the regulator on that. I think that needs to be a big part of our work over the coming year and beyond. I think there's foundations to build on, that's for sure, in terms of the means by which we do get feedback. I mean, our NHS patient survey program, which is our biggest collection of data, we ask over 100,000 people a year about their experiences of care across key areas like inpatients, maternity, children, young people, urgent and emergency care, community mental health. And we use that independent voice that we have, because of course we're the independent regulator accountable to Parliament. We do have that responsibility to speak truth to power in that sense, and we try to use that voice to spotlight good and poor experiences of care to policymakers and the public. So, for example, our report on experiences of being in hospital for people with a learning disability or autistic people report, that things like that, our state of care report, all of those publications are based on direct feedback from patients and people that use services. So I would say that working with you, working with Healthwatch, working with other organisations that have a key role is a vital part of how we do this. I'm sure people on the call would say, we can do more and we should do more. I'd agree with that. And I'm keen to hear ideas and views on how we might get better.
Brilliant. Thank you, Julian. And you just called out the great work of the NHS Race and Health Observatory. I was at a launch yesterday where they launched their report around sickle cell. And, what really talked in there was the ongoing health inequalities that's happening to people with sickle cell. So I do think we do need to do an awful lot more. And I do sometimes worry about surveys, and I'm that's not against surveys that you're doing, but I do think that we need to think about how we're going to get to that patient voice differently.
Yeah.
We did a piece of work in an area of high deprivation recently, and we showed them a lot of health comms. And we said to them, what does this say to you? And they said, it doesn't speak to us. So we've got to look at how we're working with communities differently. And that brings me to another question, because we now have, we're on the eve of the launch of a 10-year health plan, hopefully.
Yes.
And we're hearing lots of conversation, lots of comments from our health and social care secretary that the patient is king.
Yeah.
And the anticipated focus on patient power in the long-term plan. And I go back to the mid-staffs and the Sir Robert Francis's report into public involvement. How will you and how can you, both CQC and when you're inspecting services, make sure that patients are being involved as true partners in the design and delivery of those services in the first place?
Yeah. Great question and vital. So on the 10-year plan, Rachel, I am hoping, as I'm sure you are, that it does put patients and people that use and access services centre stage as far as the ambition. And I think that we talk a lot, don't we, in health and care about patient-centred approaches. But this is an opportunity at a sort of overall scale with government to actually really enshrine that in the plan for the next 5-10 years. I think it's vital that happens. I think what that means, unpacking that then, is how we are genuinely co-producing solutions to the big problems that we've got, that there is a sort of move away from what some patients still describe as a sort of rather can feel like a patronizing approach from you mentioned that experience around NHS comms, and the sense of being done to and spoken down to. I think we've got to really challenge everyone around that and use the power of your organization and other groups who can help genuinely get that right, because I think the communication and the way we do that is vital. That is something we're committed to doing as CQC in terms of how we operate. I think the other thing is there's learning to be had, isn't there, from movements across the world as far as the way that clinicians empower patients in their care. So, I've seen many examples of patient-held records, of kind of co-consultation approaches, of giving patients many patients have often more expertise sometimes than some of the professionals they deal with, particularly those with longer term conditions. So I think setting ourselves up in that way so that as the regulator, we are holding to account and asking the questions when we go into providers about how are you empowering patients? How are you communicating effectively so you've got a co-produced approach when you're thinking about a change to a service or how you improve? I can remember in trusts I've worked in when we've done improvement programs, the best ones have always been the ones where we've involved a number of patients in the process, because actually they challenge fundamental assumptions that are often made by staff, and you get back to first principles. And that, I think, leads you to design services in a much more effective way. I think the other thing about where we are is I hope we'll make a reality of the problems that we experience of continuity of care, where the experience of a patient going through different trusts or services, where information can fall between the gaps, where having to retell the same story a dozen or more times because the records aren't all joined up. I think that integration piece is vital. I mean, a personal story, Rachel, when I had a very bad cycling accident back in 2011, I was cycling home from Wythenshawe Hospital, and a car drove into me. I broke my neck, broke my arm. I was in a pretty bad way. But the trauma care was great, but it was the follow-up, it was the physio, it was the rehab, it was all of that, which, and indeed the sort of psychological and mental health support. So I've experienced it myself, where the connectivity between different parts of our services are not sufficiently joined up. And I think that's where I'm sure a lot of you on this call have experienced some of that. That, I think, is something we've really got to focus on if we're going to get this right, and we're going to see the whole service through the lens of patients rather than the lens of sort of institutions and what they do within their boundaries.
Brilliant. Thank you so much, Julian. And I have a load of questions now for you. You're giving me more questions all the time. So I think the first question, it's probably more of a reflection, actually, is that we've a lot of changes happening with NHSE merging in with department. We all have seen duplication between NHSE and the department over the years. We have a Secretary of Health and Social Care who talks about power to local community, local place, neighbourhood. But we talk about power to the patient. So to do all of that, we have to think about patient experience in a different way.
Yes.
And I think we have to think about how we commission services in a different way.
Yeah.
We have to move to we have to move from activity to outcomes.
Yeah.
Everything you've just said there, the whole person. How will you engage patients and families to identify outcome measures that truly reflect that improved patient experience across all settings?
Yeah.
And a second part to that question, because we are today in the middle, on the verge of quite a historic vote in government.
Yeah.
A lot of people when they were registering, specifically asked about sensitive areas like end-of-life care, where the current metrics may not measure or capture what matters most to those people involved.
Yeah, great questions, and so important. So the question of outcomes is such an important one, isn't it? I think there's one of the criticisms of CQC in the Penny Dash report you mentioned, Rachel, was that CQC doesn't focus enough on outcomes. And actually, we need to be much clearer about, we're not just looking at process inputs, we're actually looking at the outcomes for patients. Now, if you go back to again, the sort of best global evidence, you look at the Institute for Healthcare Improvement, the work of Don Berwick and others who've been world leaders really in safety and quality. they define quality as patient outcomes and experience. So it is the outcomes and the experience, population health, and also efficiency, because as well as being patients, we're taxpayers. So we want the NHS to be efficient, and often my experience is higher quality healthcare does cost less, in terms
Yeah.
of mistakes are costly, infections are costly. So we want to be efficient. And that I think is a helpful definition. Incidentally, the IHI have since added staff experience and health inequalities to that definition. So if we look at that through that lens, I think what we need to be doing as CQC is thinking about patient outcomes and experience. Now, we do have and have had, there's been a movement for some years around patient reported outcome measures, which are exactly what you describe, the things that matter most to patients in their care. That's a suite of metrics that I'm interested in how we develop as CQC to use in addition to what you'd regard as the traditional objective outcome measures on mortality, morbidity, infection rates, on waiting times, and on the measurable sort of quality of surgical care and treatment. And there's been quite a lot of work that's been done. For example, there's a program called Getting It Right First Time, which I've experienced, which is good, which is a team that Professor Tim Briggs leads. They go around all the hospitals in the country and they look in detail at all of the different clinical measures to find and promote best practice. We need to use some of that in our work, but I think as well as having the very clinical sort of professionally led measures, we need those patient reported outcome measures alongside them, because like you were saying about end of life care, sometimes it's not what the professionals might regard as the key outcome. It's the experience of patients, and it's the patient priorities that we need to reflect. And I would hope that in the 10-year plan, we see some of that articulated and made clear about where we need to go. And I think there's an opportunity for us to strengthen the role of the National Quality Board on that. I think that if the National Quality Board sets out a very clear approach to the importance of patient outcomes, as well as those sorts of professional clinical outcomes, we'll get hopefully the right blend and balance that everyone feels confident genuinely reflects the key concerns that patients have about their care and treatment.
I think, yeah. I think sometimes that some of the measures that we have within the healthcare system often measures the impact on the system. And I think we need to throw that in our head, because you just talked about us being taxpayers, and we need patients to live their best possible lives. And as individuals in society, we want everyone to live their best possible lives. And that is what health and care is there to do. It's to support us. So we need to measure what's important to patients much more than we are doing at this moment in time. And I hope that when we get you back again, you're going to be able to tell us how that is happening as part of the CQC inspections. I think the other bit for me is culture, and you've been alluding to it in the conversation we're having here. And I think that positive culture, and we talked about philosophy of care for staff. How important do you think a positive culture in a healthcare organization is for good patient experience and outcomes?
I think it's fundamental, Rachel. I think it's very. I'm sure you, and indeed a lot of people on this webinar have had those moments in your lives when you sort of everything crystallizes around a sort of understanding of what the fundamentals are. And for me, I think working in the NHS for a lot of years, I think the realization that actually the culture of a healthcare organization is at the absolute heart of how we deliver safe and effective care for patients. And if we just explore that, there's a body of evidence that supports this. So if you create an open, positive, learning culture where staff feel psychologically safe to raise issues and concerns, what that means for patients is a safer, more positive, engaging, supportive, compassionate environment in which to receive care. Where we can go wrong and have gone wrong, where people have seen in many inquiries and reports, is where a culture is closed, defensive, um, unwilling. People feel frightened of speaking up, of raising issues. So I think this is central to the question of how do we, across health and care, deliver safe and effective care. I've always been a big fan of the work of Professor Michael West. He sets this out very, very clearly. I know it's something that you, as the Patients Association, have done, a lot of work on and said how important this is, but in a very practical way, because culture can sometimes sound a little bit nebulous, but actually it's very real. I'm sure all of you, when you go into a health and care setting, into any hospital or GP clinic, you know pretty quickly the kind of organization that is from the way that the staff behave, how you're treated, whether you're kind of directed to where you need to be. There's that open, welcome, friendly approach, and that is not an accident. That's an approach to positively create a culture in an organization that does that. And then when it comes to the importance of being able to speak up and being able to when things go wrong, because things do go wrong in healthcare. But the vital thing is there's learning, and there's that sort of embracing of the issue, and there's the openness around that. I think the introduction of things like the World Health Organization surgical checklists and other safety features mean that you're trying to create an environment where professionals at different levels feel very open to challenging one another. We've learned quite a bit from the airline industry on this, how you cannot allow professional hierarchies to get in the way of open conversations about, we think something's wrong. Are we sure we've got the right limb here? Are we sure we've got the right sort of drug here? All of those things where junior members of staff often will have insights that maybe more senior colleagues have missed. So vital that is encouraged, and that is all around developing a strong patient safety culture. So I think we know, and we've got enough evidence to understand what that is all about. That's why the work that we do when we do our well-led reviews is so important, Rachel, because it does look at those areas about the sort of culture, about the approach, about the openness, and you learn a lot from things like staff surveys, from staff focus groups, because if you get it right with the staff, they'll get it right with patients in terms of the work. So that's why I think, and I do hope again that we see an important emphasis on this in terms of the plan. And certainly for us, it's going to be a very important part of our work. And we're having to do our own piece of work on culture in the CQC, because our culture is not where it needs to be as yet. And as the regulator, we should be setting the example, shouldn't we?
Absolutely. And another question, but I will come back to that question, is to talk about the measures that you're taking to ensure the right culture at CQC. But I want to come back to the professional hierarchies to start with. And I want to reflect on, the story of Martha Mills, where Martha's Rule came in this year, and we were very honoured to be on the advisory group that worked with the Patient Safety Commissioner on that. And that was really a story, Martha should be here. That was the story of those professional hierarchies just not listening to the patient, and in this instance, Martha's parents.
Yeah.
And then I want to take that to our helpline, so our free phone helpline that works with you on Tell Us Your Care program. And the number of calls, the hundreds of calls that we get through there where patients are talking about not being listened to. They put in, they're trying to raise a complaint, and they find themselves pushed from pillar to post.
Yes.
And they find that the communication and the admin, which we know is across the whole of the health and care system, that needs something improving with. How will CQC look at that? Because I think a lot of that is about the value of the complaints team. It's about who's looking, who's listening to the complaint, who's responding to the complaint, and are we really listening to what the patient is saying about what's happened to them? Because majority of patients want their care to get better, but they want care to get better for others in the future too.
That is absolutely right. So a few things on that, Rachel. I mean, I think it's tragic, isn't it, that we retread some of the cases like Martha Mills, and I think it's, incidentally, actually, it's good to see Martha's rule actually implemented across the NHS and the use that's being made of it.
And how crucial it was that it was implemented.
So that's positive. However, we shouldn't have been there in the first place, should we? And I think that in terms of your question about us and about how we do this, I think first of all, coming into the organization and having to deal with a significant backlog of information of concern cases were issues that have been raised into our national contact centre by patients and other concerned members of the public. We've redoubled our efforts to sort of make sure that we've got the right capacity. We invest in training. I think it's important that we have skilled operators being able to engage with members of the public when they call into us. I spent some time a couple of weeks ago. It was so valuable. I spent an afternoon sort of listening with colleagues who take those calls, just to hear firsthand the range and scale of concerns that are fed through. And it is humbling, actually, when you listen to the difficulties and challenges that many patients have experienced. We use that data and we collect that. And I think that how we use that to feedback and ultimately improve, because your point about this is all about, and the motivation is often, look, this has gone wrong for me. I don't want this to happen to someone else. So there's got to be a really strong feedback loop and learning culture that I think we should be part of as CQC, as the regulator, to demonstrate that we're able to spot the trends. If it's around a particular provider, make sure they're aware and that we're checking that action is being taken. And crucially, feeding the work we do back publicly so everyone can see what has happened as a result of the concerns that are being raised. Because I think that confidence that, a lot of patients or service users will say, well, I've fed this back, but nothing's happened. And it's trying to demonstrate that actually the issues and themes that we collect, because we aggregate all of those concerns, actually do lead to action, do lead to change, do lead to improvement. So I think it's one of the big challenges we've got to get better at. I don't think it's hard to say you ever get there, isn't it? Because there's always more to do with this. But I do think we can perhaps do better. But I think the first steps are capacity, making sure we can respond quickly, making sure we've got the right training, making sure the people that are speaking to people that ring in are effective and skilled, and indeed making sure that providers, when we feed back all of those issues and concerns, are prepared to change, improve, and respond to those themes.
Thank you. And Julian, I think thank you to the audience who are putting in some questions to the Q&A, which I'm obviously keeping an eye on, and I think we're addressing them all. I think for just as a reflection there, and I think we've reflected on this during the conversation, is making sure that the CQC are getting to those voices of people who are not heard. So, people who are homeless, refugees, people in prison, the stories that we hear every day where healthcare isn't good, that they feel part of the solution.
Yeah.
And
Yeah.
if we have a philosophy of care, and we have, freedom to speak up guardians, and all of those, we need, that culture needs to say to patients and their loved ones, it's actually okay for you to speak up. We
Yeah.
really want you to.
Yeah.
Because I think too often, and especially when it comes to some of the calls that patients don't want us, or they don't want to report to CQC, part of that is a fear, because
Yeah.
they're saying, if I report this, will that place know that I've reported them, and will that have an impact on, my elderly loved one in a care home? And I think
And
that's a real genuine fear from patients and their
yeah.
families and carers and close loved ones.
And I mean, just on that, Rachel, I mean, we obviously preserve confidentiality in all of our processes, and what we do is we take feedback, but we make sure that that is not done in fed back in a way that could attribute it to an individual. That we make sure there's a thematic reflection back, and we look at the volume and nature of the concerns that we get from about an individual provider, say, and triangulate that, and then so I wouldn't want anyone to feel that they are at risk of being being experiencing repercussions as a consequence of getting in touch with us. We handle that feedback with the utmost confidentiality, and we make sure that we're not the organisation that deal with individual patient complaints. We are the organisation that makes sure we hold providers to account for the quality of care they are delivering. And what's vital is that we have that feedback from patients in order to be able to get those providers to address the issues raised without attribution to individuals, and make sure that we are supporting those providers to improve where it's clear there's a range of concerns coming in, say, on a similar theme. And we call those responsive inspections. We respond to concerns that come in to us, and we look for patterns, we look for trends, we look for themes, and we, as part of our inspection, spend a lot of time talking to individual kind of patients or families who may have key concerns, but that obviously is fed back in a way that is confidential and doesn't create the problems that some of that your question implies that some people might be worried about. So I just want to make sure that's really, really clear.
No, that's really, really helpful. We are running out of time, and I still have 2 or 3 questions that I definitely want to get to you. So I'm going to ask you to be as concise as possible. So you talked about your staffing. You talked about the new chief inspector, some of whom I know, and I think they're great appointments. So the 2 questions there is, with these new people in post, how will you ensure the consistency of inspection standards across the organisation? Because I think that was an issue, and that's where some of the trust issues have appeared.
Absolutely. That is such a central question, and it's one that we get asked a lot. So I think part of the problem and the difficulty we've been in is that that single assessment framework I referred to was based on 34 quality statements, which, when you read them, there's so much room for interpretation in each of them. I think we need to be much more specific and clear about what we are looking for in each of the sectors, which is why we're going to get the chief inspectors to make sure that we're very clear based on patient feedback in terms of back to the outcomes patients want to see, and also those points about quality and experience and outcomes is that and indeed culture, is that the what we call the assessment framework is specific and clear. It's measurable and it's transparent, and it can be understood by anyone looking at, this is what we are looking for. This is what good looks like. This is what outstanding looks like. This is what requires improvement looks like, and so on. At the moment, that is not as clear as it should be, and it's led to a lot of confusion, and in turn it's led to some variability in interpretation, which is why, you know, some of that variation that you're describing. So step one for us has to be real clarity around our assessment framework, making sure that it supports consistency, and that we have a very good second step, a very good moderation and quality assurance process, where those chief inspectors get their teams together and say, okay, we've been into these trusts or these care homes. Let's triangulate. Let's make sure we're moderating effectively. Let's make sure our judgments are consistent and that we are not taking a different interpretation on a different statement or line of inquiry. I would rather get us to a point where we can use objective, evidence-based data, which then minimizes and mitigates that risk of variation, that risk of sort of variability, where one provider could turn around and say, well, they got good over there, we got requires improvement, but we can't see any difference in what we are providing. So I would also say that the way that patients and the public help shape that is important. We ran a whole series of big events earlier this year, which quite a lot of providers, but also patient representative groups came along to make sure that we were having the conversation directly about what we should be looking for in any provider and how we assess that and how we shape that. So that longer term, we'll have a comprehensive public engagement strategy. It will help improve how we listen, inform, and involve people and services in shaping that assessment framework. So it's transparent, clear, but crucially, it can be iterated and improved as we develop.
Brilliant. And a plea from the Patient Association to ensure that patients and the public are involved in the development of that strategy.
Yes.
So we're down to our last few minutes, and we still have some questions in the Q&A, and I'm going to ask a couple more, but we are going to take the Q&A questions and just make sure people get responses to them afterwards. So you'll be sending you out a link to this with questions if we don't get to them. So Julian, it's 2030 and the CQC has truly transformed. What would be different for patients when they walk through any health and care setting?
Great. Really good to envision the future, isn't it? So what will be different? First of all, I would hope that even before they walk into that setting, it's been very, very clear how to navigate the system, that it's been that they're really clear about where to go and why, that they don't feel passed from pillar to post, that the information is high quality, they know what to expect because that provider has given them accessible, real-time, kind of understandable information about where to go, what to expect, and that the that they're set, as they set foot through the door, they're already well informed about what's going to happen, who they're going to see, how things are going to work, and indeed that they're not going to be waiting all morning or afternoon for the attention, because that provider is responsive and effective in terms of how it allows patients to access it. Secondly, I would hope that from us, they've been able to see very transparently our observations on that provider in a way that's understandable, that's clear, that's timely, that's up to date. One of the problems, of course, for us has been how out of date a lot of our ratings are because of the problems that I described. So you know, you can either go online or you can see in the waiting area of that provider the CQC readout on that provider that's very clear, that's easy to understand, and gives a sense of transparency about where it's strong, where it's improving, what it's focusing on. The other thing I would say is that as you walk in there, the culture of that organization is such that you're greeted warmly, that you feel part of the experience in the sense that your feedback is welcomed, that your opinion is sought, and that when you have your consultation with the professional, it's one that doesn't feel talked down to, or you know, patronizing, or in any way made to feel that you're the junior partner in the conversation. I think that the importance of that empowerment of patients is going to be the story of the next 5 years, I hope. And then I hope that the after the consultation or the treatment or so on, it's very clear what to expect. It's very clear what happens next. It's very clear what the means by which you can feed back on that experience is, and that, you know, your feedback is going to be taken seriously by people like CQC, who will use that to then be able, when you next turn on your radio or television or go online, when we speak about services and the state of care, you recognize what we're saying because it's based on the feedback that you've actually given as a patient, and you see the themes and issues coming through in our work because we are much closer to you and to what's happening based on the work that we're trying to do over the coming months and years to really strengthen our approach to regulation, to protecting all of you that use services and using your feedback to get them to improve.
Brilliant. Thank you, Julian. If you achieve all of that, you also achieve the patient association vision of patients being true partners in their individual care and in the design and delivery and redesign of all services within the system. Spot on time. We're just up to 10:30. Julian, thank you so much. It's been really helpful, and I hope that you'll come back next year and let patients know actually where you've got to on this journey. And obviously the patient association is here to support you as you go through that journey, you and your team.
Love to. Look forward to that, Rachel. Thank you.
No, thank you so much, Julian. So thank you all for attending. I think there's a couple of slides coming up. One is just telling you about the rest of our Patient Partnership Week events. And you can register for these on our website. So looking at outpatients, some of the issues that we brought up with Julian here, the breaking down barriers to equitable care, digital. Then we have Sir Jim Mackey, the Chief Executive Officer at NHS England, telling us how he's going to get things back to basics and really put patient experience and partnership at the heart of what he wants to achieve. Something about the patient partnership, which I've talked about a lot here today. And then how do we really champion patient voices? So I hope that you're able to attend some of those. They will be available on our website as well. Some of the issues that we have spoken about here today are issues that we've heard through our free phone helpline. So the number is there. It's no 800 number. And obviously we are a membership organisation, so we'd love you all to join us. It's free, and it's just great to get your voice, and we can always ask you questions about what you're thinking, and help us kind of define our future. So I think that just leaves me to say goodbye, and thank you so much for joining us, and have a fabulous Friday, everybody. Thank you so much.